Hi, my name is Dr. Anita Jacobson, and I'm a clinical professor at the University of Rhode Island College of Pharmacy, and I'm also the program director for the Community First Responder Program. I actually came to URI as a student, so I started in 1992 in the College of Pharmacy, did my Pharm.D, and then did 2 postgraduate residencies, one of which was affiliated with the university. I have really been working in the area of opioid use disorder, more specifically with Naloxone distribution to communities to help people know how to recognize and respond appropriately to an opioid-related breathing emergency. I lost a family member to an opioid overdose in 2014, and so that really has driven my passion to being involved with this. And I really find that knowing from a first-hand perspective the impact of opioid use disorder really helps connect me to the community. My course is really a skills-based course, so it's a practice lab, and different from traditional laboratory classes where you think of using pipettes or doing things with boiling point. Our lab is really focused on patient-provider communication, so we give the students a lot of opportunities to practice navigating patient care scenarios, simulations with actors, as well as high-fidelity human simulators for more hands-on work. Really what we want students to come away from our course knowing is how to talk to diverse patient populations and have the tools and education to effectively help someone without being afraid, with real confidence that they can effectively save a life. So we want everyone to know how to reverse a breathing emergency if it were to occur, to have Naloxone at home. We want everyone to consider themselves a community first responder.
Hello, everyone. Thank you for joining. My name is Karen LaPointe, and on behalf of the URI Foundation and Alumni Engagement, I'd like to welcome you to today's program. We're very pleased to kick off our Fall Faculty Office Hour series, where we drop by a professor's office for a chat about their teaching and research. And this fall, we're exploring the theme of brain health. Today, we welcome Dr. Anita Jacobson, clinical professor at the College of Pharmacy and program director of the Community First Responder Program at URI. And serving as today's moderator is Maciel Frias, program coordinator of the Community First Responder Program and a licensed psychotherapist experienced in treating substance use disorders. If you have questions for Dr. Jacobson, please post them in the chat section on your screens. We will do our best to get to as many questions as we can after the presentation. And just a note, today's program will be recorded. In a few days, you'll receive an email with a link to the recording, along with recommended resources for further reading. You'll also be receiving a very brief survey from us, and we would welcome your feedback. Now, I'd like to turn the program over to Maciel.
Thank you, Karen. Welcome, everyone. I'm so happy to be here and so glad that you can join us. Today, you'll meet Dr. Anita Jacobson, a clinical professor at the College of Pharmacy, program director of the Community First Responders Program, and a practicing pharmacist since 1998. She serves on the Board of Pharmacy for the state of Rhode Island and maintains her clinical practice at Eleanor Slater Hospital. Dr. Jacobson's area of scholarship and practice include behavioral health care, harm reduction, and substance use disorders. She focuses on improving pharmacist-patient communication, especially related to vulnerable patient populations and conditions associated with stigma, such as mental health and substance use disorders. Now let's hear from Dr. Jacobson.
Thank you, Maciel. I'm excited to be here today and to share information about the Community First Responder Program with everyone. So with that, I am going to share my screen with you all. Okay, great. So for our program to get started, I just want to let everyone know that this program does outreach in Rhode Island broadly, so that if after hearing this presentation you're interested in getting a Naloxone kit, that is something that we can absolutely do. feel free to reach out to us after the program. So it's important for me to acknowledge that this project is sponsored by the Substance Abuse and Mental Health Services Administration of the NIH, and the contents are solely our responsibility as the authors and do not necessarily represent the official views of the NIH. So I'm going to start out looking at some data, looking at opioid overdose nationwide, and then zooming in on the state of Rhode Island. So drug overdose is now the leading cause of death among Americans under the age of 50. It's important to note that the epidemic has really spared no one, regardless of age, race, ethnicity, socioeconomic position. Everyone likely knows someone who has been touched by the opioid overdose epidemic. It also affects children. There has been an increase in pediatric poisonings related to opioids. A lot of this may be due to recreational exposure, but a large percent is also due to accidental exposure from people having prescription opioids in their home, perhaps a parent or grandparent's medicine cabinet that young people have access to, which is one of the things we always advocate for, is making sure people lock up their controlled substances, opioids, and other potentially harmful prescription medications so that children don't get into them. So if we look at the history of how we got to where we are currently, beginning back in the late 1990s, which is a time when I was doing my residencies at Rhode Island and Miriam Hospital. And I vividly remember back at that time, pharmaceutical company representatives were allowed to come onto the units, into the ICU, onto the general medicine floors, and talk with us about their products and medications. And I vividly remember drug reps coming in and talking about the medication OxyContin, which was being touted as a non-addictive remedy for pain, particularly arguing that because it had a long duration of action, it avoided the peaks and troughs that we see with shorter acting opioids and therefore would have less potential for misuse. So that information that we were getting at that time, coupled with pressure to achieve 0 pain scores for patients, pain was considered a vital sign that needed to be assessed on every shift with our patients, and it was considered to be inhumane for people to have any pain following an injury or a surgical procedure. So those two things coupled together led to an increase in prescription opioid prescribing and a subsequent increase in overdose deaths. In 2010, we begin to see a rise in heroin-involved overdose deaths. Most of this is representative of a crossover from other opioid use to heroin. It's relatively rare that I have a patient who reports that heroin was the first opioid that they were ever exposed to. Now, this could be recreational or legitimate medical use of prescription opioids that later results in a crossover to heroin. In 2013 and then precipitously in 2014 and 15, we begin to see a rise in synthetic involved opioid overdose deaths. And this is really due to illicitly manufactured fentanyl. So this photo shows equipotent amounts of heroin, fentanyl, and then an analog of fentanyl known as carfentanil, which is sometimes also referred to as an elephant tranquilizer. So you can see it is only a few granules of fentanyl to be the same potency as a much larger amount of heroin, and then only 1 granule of carfentanil. You can also see in this photo that these substances, they're all white, they're all granular, they look the same. So someone who is using unregulated substances like cocaine or heroin, would not know that fentanyl was in the product that they had. It's not something that they could see or smell or be able to detect. And this is starting to increase in counterfeit pills as well. So we've seen an increase recently in counterfeit opioids that are being sold and have fentanyl as a major ingredient and resulting in overdose deaths. So if we zoom in a little bit on our state of Rhode Island, so this map shows overdose deaths by city or town, and this is from 2014 to 2018. And you can see that the concentration in orange and yellow really is in our more urban sections of Rhode Island. However, this is by city or town where the fatality occurred. If we look at this next map that shows the counts of overdose deaths by municipality of residence, so city or town where the person lived, we begin to see that while, yes, still concentrated in the dark red areas in the more urban sections, some of our more rural communities are certainly experiencing overdose deaths as well. And this is data just for 2020. So we can see Burrillville, Gloucester, Scituate, Coventry, West Greenwich, Exeter, Hopkinton, Westerly, North Kingstown, Newport, and other more rural sections of Rhode Island experiencing overdose deaths in their city or town. So if we look at the 12-year history of the overdose epidemic in Rhode Island, you can see that there was a steady increase between 2009 to 2016, going up every year. And we began to see a little bit of a dip down and lower rates starting to occur in 2017 and 18 and 19. However, 2020, with the pandemic, we saw a dramatic increase. And in fact, 2020 is the highest recorded year on record since the Department of Health has been collecting that data, with 384 overdose deaths in 2020. Among cocaine-involved deaths, what we're seeing now is the vast majority also involve fentanyl. So as I mentioned, fentanyl is becoming increasingly ubiquitous in unregulated substances. So whether it's counterfeit pills, heroin, cocaine, we are seeing fentanyl coming up and being responsible for overdose fatalities. So this is a quote from the former Surgeon General Jerome Adams. "If we want to make a dent in this overdose epidemic, we need everyone to consider themselves a first responder. We need to look at it the same way as we look at CPR. We need everyone carrying naloxone." So this is actually where we got the title of our program, the Community First Responder Program. And this is certainly our motto. We feel strongly that we want anyone who is willing and able to have naloxone to carry it with them. You never know when you might encounter someone. We've had reports of people rescuing someone in a parking lot, on an Amtrak train, different locations. So you just never know when you might encounter someone. We also want people to recognize that having naloxone is to help anyone who is experiencing an overdose from either recreational substances or from prescription opioids. Even if someone's been taking an opioid medication for many years, they can still have an opioid-involved breathing emergency, and naloxone is the antidote for that. So if we look at pharmacy and community-based naloxone distribution in Rhode Island, you can see on this map the areas concentrated in the darker green, the more urban sections of Rhode Island, have had the highest numbers of naloxone distribution in our state. So our program has been focused more on the areas in the yellow and lighter green, so the western corridor, the southern section, and the East Bay areas of Rhode Island. So to address the growing opioid crisis, particularly in our more rural communities, our program, which is funded by the Substance Abuse and Mental Health Administration and also is being led through the Cooperative Extension Program at URI, so some of the original land grant agricultural components of the university. So we, the College of Pharmacy, the College of Nursing, and Cooperative Extension have partnered together over the last 2 years to create the Community First Responder Program. And our goal is to be out there in the community, educating rural communities about substance use disorder and opioid misuse, and then providing resources to people to help address opioid misuse and also to be able to recognize and respond to an opioid-involved breathing emergency. So oftentimes when we're out in the community, we do face a lot of stigma from people not really understanding opioid use disorder. And we really try to spend a lot of time providing education, helping people understand what opioids are and how people can go on to develop an opioid use disorder and potentially addiction. So opioids fall into different categories. So our more strong and powerful opioid agonists, and an agonist is a substance that binds to a receptor and creates a change. So for opioids, we're predominantly thinking of the mu receptors in the brain, and we're looking for pain relief. So these are effective medications, certainly for cancer pain, end-of-life pain. These are important medications for us to have in our toolbox to help patients. So our more powerful ones include morphine, fentanyl, methadone. Methadone is worth pointing out that it has a few different properties. It has a very long duration of action, and it also has a ceiling effect so that we can get people stable on a dose of methadone for months, years, or even decades. They can be maintained on the same amount and help to control cravings as well as preventing withdrawal symptoms. So because of those properties, methadone is uniquely positioned to be a treatment for opioid use disorder, which sets it apart from some of the other opioids in this category. Heroin, hydromorphone, oxycodone, which the long-acting version is OxyContin, and the short-acting that also contains acetaminophen is Percocet, and then meperidine. So these are some examples of some more potent opioids. Some moderate opioid agonists include codeine, which you might commonly think of in being cough suppressant or in some cough and cold prescription products, and hydrocodone or Vicodin, which also is coupled with acetaminophen. We then have some other more unique opioid agonists, tramadol, which also has some effects on the neurotransmitter serotonin, as well as dextromethorphan, which up until recently was easily obtainable in over-the-counter products. So things like Robitussin or NyQuil. Now there are more age restrictions and checking IDs when purchasing products that contain dextromethorphan, but that's a relatively recent change. I remember working in community pharmacy, and after a night shift, we would find empty bottles of cough and cold preparations that contain dextromethorphan in the parking lot. People would consume large quantities to get hallucinogenic effects, so it can be misused. There's also a partial opioid agonist, buprenorphine, which you may have heard under the common name Suboxone. So this is another effective treatment for opioid use disorder. We can get people on a stable dose for months, years, even decades to help prevent cravings and to treat that withdrawal that they might experience if they were trying to stop using substances suddenly. And then the opioid blockers. So I'm going to be focused for the rest of the presentation on Naloxone or Narcan, but there is a long-acting one, naltrexone, that you may have heard of, and this is administered every 4 weeks by intramuscular injection. It is not an effective reversal agent for an overdose, but it is another tool for treating opioid use disorder to help to resolve cravings that are associated with that. So certainly the pharmacology of what's happening with opioids in the central nervous system is complex. I mentioned mu receptors, but there's kappa, delta. So it's a complex system. However, what I do want to discuss is the fact that opioids in our central nervous system can have different effects for different people. So for a percentage of the population, when they have opioids, say they have an injury or they have their wisdom teeth out, they may say on exposure, I felt awful. I don't understand how anyone would go on to misuse this. I had a dry mouth. I felt sedated. I felt disassociated from my body. I felt nausea. So, these are different reactions that actually the majority of the population experiences with exposure to opioids. However, for a percent of the population who's vulnerable to the disease of addiction, short exposure to opioids, either recreationally or for a legitimate medical reason, can lead to feelings of profound euphoria. I've had people describe it to me as slipping into a warm bath, of feeling all the problems of the weight of the world being lifted. And it leads to feelings of great pleasure and euphoria. And so those individuals, about 20 to 25% of the population, are vulnerable to the disease of addiction. And we don't fully understand. There's some genetic as well as environmental factors. We don't fully understand how to screen for that. So there's some screening tools, not perfect, but it's difficult to know who may be susceptible to addiction to opioids with even a short exposure. So how do people move from prescription opioids to heroin? I mentioned before that very rarely do I have someone who heroin was the first opioid that they were exposed to. And it's typically due to cost and access issues. So the cost of heroin, much lower to be purchased recreationally compared with prescription opioids or even counterfeit pills, and also more available. So what percent of people are at risk for developing an opioid use disorder? So I mentioned that 20 to 25% can be considered vulnerable to the disease of addiction. However, we do find about half of those will self-select out. And this is, again, not well understood. It may be due to environmental factors as well as family and social support. But we do have a percent of people who, on exposure to opioids, say, I know where this is going. I can see, that I have this euphoria and desire for the substance, and they self-select out from not using opioids again. And that's, something that we need further research to understand and to try to bolster in individuals. But for about 10 to 12% of the population, we do find that there will be misusing opioids a year later after exposure. The driving factors for continued opioid misuse include that desire, that craving, those feelings of euphoria, losing control of use over time, using larger and larger amounts to get the same effect. This is due to tolerance that builds up. Just like with alcohol, someone who drinks alcohol regularly can drink much larger amounts than someone who is alcohol naive. Same thing with opioids. People can, over time, build up a large tolerance and be using very large amounts that would be fatal if someone who is opioid naive were to consume or ingest that substance. People spend their time, their money, their effort getting their next dose of opioid. It becomes all consuming. But the main driving factor is actually withdrawal. Patients have described withdrawal to me as being the worst experience of their life. They have described it as the worst stomach bug that you've ever had in your life, with the worst influenza symptoms, with a whole ton of anxiety sprinkled over the top of that. And people really are desperate to avoid going into withdrawal. And it's important for us as healthcare professionals to mitigate withdrawal, to prevent withdrawal for our patients through medications like methadone and buprenorphine that I mentioned, and to really make that transition into treatment for opioid use disorder smooth, and to avoid those withdrawal symptoms so that people aren't, likely to relapse due to those debilitating symptoms. So overdose risk factors in naloxone. So overdose occurs when there is a toxic amount of substance in the body. And with opioid overdoses, it's specifically respiratory depression, so inadequate breathing. So I actually tend to talk about this when I'm out in the community as an opioid-involved breathing emergency. There seems to be a little less stigma associated with that. Unfortunately, the term overdose sometimes results in a stigmatized response. So this is because it is a breathing emergency, it leads to a lack of oxygen in the body and will eventually lead to death if no intervention is made. So it is possible for people who are experiencing an overdose to still have a pulse. So you typically see lowered respiratory drive, so their breathing rate will slow down. They may be pale, have ashen skin. They may have blue around the mouth or the finger beds due to that lack of oxygen. But the person is also unconscious. So it's important that we only administer naloxone to people who are unconscious, not people who may be intoxicated with opioids, have pinpoint pupils, be slurring their words. Those are people we want to watch closely to make sure they don't go into an overdose situation. But with an overdose, the person would be unconscious. And because of that, you need someone else to be able to administer naloxone. So when I talk to people out in the community, I always stress, never use opioids alone. Because you can't, unlike an EpiPen, where if you're stung by a bee or you have a peanut and you have an allergy, you can self-administer an EpiPen. Naloxone cannot be self-administered. So for an overdose response, if you see someone that you think might be having an opioid-involved breathing emergency, so they have that slow or shallow breathing, they're unresponsive, they might have some signs of low oxygen in the blood, immediately calling 911 is important. And then administering naloxone if it's available. If there are two people available, we always advocate that one person calls 911 while the other person is administering naloxone. And if that person doesn't respond after 2 to 3 minutes, we advocate for giving a second dose of naloxone. What we do find, and I have only had to do CPR once in my life on someone, and we do find that time sort of loses all perception when you're in that high stress situation. So we really do encourage people to potentially set a timer on the phone, because we find that sometimes naloxone is administered one after the other. So people will report having given 5 or 6 doses of naloxone, but often the time that they're waiting in between those doses is very short. And I certainly understand that. It's a very high pressure situation. So how naloxone works, it's an opioid blocker, an antagonist, and so it literally pushes the opioids off their receptors. So you can see the naloxone in this cartoon as the little green bubbles that are bound to the receptor, and the opioid as the orange, which has been pushed off of those mu, kappa, and delta receptors in the central nervous system. So this doesn't actually remove the opioids from the body. So it is just displacing them from the receptors. This rapid removal from the receptors can precipitate withdrawal symptoms, those dreadful withdrawal symptoms that I mentioned, although the severity does vary from person to person. So people, may feel quite badly after receiving naloxone. They may be vomiting, they may have chills, they may have a lot of anxiety, and the mood of the person who is attending to them and providing support is highly correlated with how well they do. So that's, something we always advocate for. Staying calm, being supportive helps those individuals who are experiencing those unpleasant withdrawal symptoms to feel supported and to do well. It's also important to note that naloxone only lasts for 30 to 90 minutes. And since the opioids have not necessarily been removed from the body by the kidneys or liver in that time frame, the person can go back into a breathing emergency after 30 to 90 minutes. So that's why calling 911 is so critically important, to have that support there in case they do go back into a breathing emergency. So our program is considered part of harm reduction efforts, and harm reduction refers to public health efforts to minimize the harm associated with the use of unregulated substances. And so other examples of programs include syringe service programs, drug testing services like fentanyl test strips. I showed you the slide at the beginning. People can't tell if a substance that they have has fentanyl in it, something that they get recreationally. And so those test strips can be one way to try to detect fentanyl, although not 100% effective. Decriminalizing drug use, some countries moving towards prescribing heroin to ensure that there is not fentanyl or carfentanil or other dangerous analogs in heroin. Safe and supervised injection sites, which Rhode Island is now the first state that has passed legislation to have safe and supervised injection sites. So that is something that is coming soon. And there's some valuable resources at the bottom of this slide. NASN.org, you can search by zip code and find syringe service programs in every state in the United States. And a treatment locator at findtreatment.gov. You can search again by zip code and find treatment providers and other harm reduction organizations with that. So those are two really valuable resources, in addition to the Rhode Island specific ones, AIDS Care Ocean State, and the Rhode Island buprenorphine hotline, which is new with COVID-19. So some questions that I commonly get asked when I'm out in the community: can I travel with naloxone? So the answer is yes. It is allowed in all 50 states, and you can travel internationally as well. I just recently went through TSA with my naloxone. Nobody batted an eye at it. And certainly can, have it in a car. We do tell people, if they keep naloxone in their car, to please keep it in an insulated cooler, not with ice, but something that is insulated so that it doesn't get too hot, because as we know, cars can get very hot or very cold depending on the time of year. What if I administer too much naloxone or it isn't an overdose? You don't have to worry about administering too much naloxone with the nasal spray, although we do advocate for trying to time the interval to that 2 to 3 minutes between doses to try to avoid making the withdrawal symptoms worse for the person. But if it's not an overdose, naloxone will not harm the person at all. It won't do anything, but it won't help them either. So it's very important to look for cues. If you see someone who's unconscious and doesn't have breathing or a pulse, you still want to do CPR. You still want to look for an emergency response tag to see if maybe they have diabetes or another medical condition, because giving naloxone wouldn't be harmful, but it also won't provide the support that they need. Will the person I give naloxone to be combative with me when they wake up? So this is a myth that has unfortunately gained a lot of traction and has been successful in scaring people from helping someone who is having an overdose, and it's very unfortunate. People may experience withdrawal, they may be vomiting, they may feel badly, but the reports of combativeness are not supported by data. We just don't see this, and it really just serves to add to stigma. Will naloxone or fentanyl test strip distribution enable heroin use? And so this seems kind of intuitive. Here we are giving out naloxone, fentanyl test strips. Are we encouraging people to use unregulated substances? And again, the data just doesn't support that. Communities that have robust naloxone distribution programs don't see a compensatory increase in the use of unregulated substances. What they do see is a decrease in emergency department visits for breathing emergencies. So the data just doesn't support that it's enabling heroin use. Can I give my naloxone or fentanyl test strips to someone else? So yes. So if you're watching this program and thinking, you'd like to email me at the end to get a kit, maybe someone who has, a child or a loved one or a friend who's struggling with opioid use disorder, absolutely, can transfer that to someone else. We just ask that you refer them to our program for education so they know how to use it. And then, is fentanyl something I will inhale or absorb when trying to help someone? So this is another myth. It has gotten a lot of traction in the media. So fentanyl powder cannot be absorbed through the skin. So unless someone was snorting or injecting or came in contact with a large volume of aerosolized fentanyl, which I can't picture really the scenario where that would happen unless it was purposeful. So the reports of people having a passive fentanyl exposure and then needing naloxone, there's never been a verified case where with running toxicology, we were able to verify that there was a fentanyl exposure. So it may be a panic attack. It may be recreational use that someone's covering up. It may be, I think I would panic if I got a white powder on me that I thought was fatal. So there could be a lot of alternate explanations, but fentanyl powder can't be absorbed through the skin. So currently, and I apologize, this slide got a little squished, but so our current activities, we're doing naloxone distribution at farmers markets. We've partnered with CVS to go to rural locations, and we also do send naloxone out via the US mail. We have interactive training modules at uri.edu/CFRP. They're fun, they're interactive, they're engaging, and people can request a kit to be mailed to them after doing the certification program. We have a collaboration with the Department of Health and Prevent Overdose Rhode Island to do their website, and not the whole Prevent Overdose Rhode Island website, but to do their training, just the little training section, and to mail naloxone for the Department of Health. And we do continuing education programs for healthcare professionals, so social workers, mental health counselors, physicians, nurses, pharmacists, physician assistants, nurse practitioners. All of those disciplines are eligible for free continuing education credit, including law, at our website. We've also collaborated with every single rural police department in Rhode Island, I'm happy to say, to provide leave behind kits. And I'm going to talk a little bit more about that in just a second. And then we also do webinars on request for people. It can be an in-person or over Zoom or another platform for groups. So whether it's a library group or an employer group or a church group or whatever it might be, we do trainings for groups on request. So these are some photos of our events being out in the community. That's actually Maciel in the larger photo there on the right. And so our students and, really it's just been such a great collaboration of nursing students, pharmacy students. We have pharmacists who are out in the community who have volunteered their time to come back. Actually, the individual with the yellow bandana in the sort of bottom middle photo is a practicing nurse practitioner who works at the VA, who volunteered many weekends to be out at the Burrowville Farmers Market to distribute naloxone. So we have a big team of people that we're very grateful to have. So the Leave Behind program that I mentioned, so these are our kits. They look like sort of a first aid kit. And we have given them to every single police department in Rhode Island in the rural communities, because that's where our grant is located. We do have a van, you can see in that photo, to go out and make these deliveries. And our hope is that when police respond to an overdose, they will leave these kits with the friends and family of the person who's having the breathing emergency, because those individuals are high risk and they're likely to be in the position to help someone and save a life in the future. So to date, we've distributed over 4,700 naloxone kits. I'm very proud of that, in basically all of the cities and towns in Rhode Island. We've had the largest number in South Kingstown, but also Burrowville, Coventry, Westerly, North Kingstown, Narragansett, in the East Bay area. So we're really trying to hit that western, southern, and East Bay sections of Rhode Island. So this is just a screenshot from our website. I hope that you will refer people to our program, because we do have these free continuing education credits, as well as education for the general public and the ability to request a seminar. So looking to the future, our grant funding did end in September of 2021. So we finished our 2 years with SAMHSA. So we're looking for additional funding opportunities and grants. We're always applying for things to fund our program. We are expanding that collaboration that we have already with the Department of Health and Prevent Overdose Rhode Island. And we're currently looking at potentially becoming the hub for naloxone distribution to all the community partners in Rhode Island. So that's something that is, hopefully coming in the future, looking to January 2022. And again, it's a big team of folks. I want to especially thank Maciel Almond-Frias, who is my program coordinator, as well as Diane Martins in the College of Nursing, who is a program collaborator. And really, she has just given so much to the program. And then, as you can see, we have a huge student research and outreach team. So they really are the heart and soul of the CFRP. They're out in the community. They're giving out naloxone. They're meeting with people, they're dispelling stigma, answering questions. So we're very proud to have them. So with that, I would be happy to take questions. Hi, Maciel.
Thank you, Dr. Jacobson. Now we have a few questions from the audience. And just a reminder, if you do have a question, you can enter it in the chat section on your screen. And let's start with, who should have a first responder kit?
So again, we kind of are advocating, and the motto of our program is we want everyone to be a community first responder. You just never know. You could be going to the grocery store or, whatever it is, and you could encounter someone who's having a breathing emergency. So just like we want everyone to know the Heimlich maneuver, we want everyone to know basic hands-only CPR, anyone who has basic first aid training and knowledge, we would definitely advocate for them to have a naloxone kit.
Mm-hmm. And I've seen on the news that there's a shortage of naloxone. What is causing the shortage, and how has this affected the Community First Responders program?
Yes. So this is sort of a two-pronged issue, actually. There is a shortage of naloxone, the generic version of naloxone that is the intramuscular injection formulation. So the intramuscular injection is a much lower cost option for people, but it also can be a little more challenging for lay people to administer. But for our programs that are working with high-risk individuals, so people who are using unregulated substances like heroin, they do predominantly distribute the injectable naloxone, and there is actually a manufacturer shortage of that. So that is something that is ongoing, is hopefully, being resolved going forward. Our program only distributes the naloxone nasal spray, which is under the trade name Narcan, which is what most people have heard of. So there is not a shortage of Narcan. Narcan is available. There's not a manufacturer shortage. There's a shortage of funding. So we don't have a sustainable source of funding in Rhode Island as a line item budget item for naloxone. So we tend to wind up, and we're in that situation now towards the end of the year, September, October, November, with funding shortages to purchase enough naloxone Narcan to meet the needs.
And is there any information about why the pandemic has led to an increase in overdose incidents?
So it's likely due to the isolation, to the mental health aspects, to employment difficulties, to relationship challenges, to that family and friend and relationship support that may have been affected by the pandemic, and people who are in recovery potentially going back to using an unregulated substance. Or because of mental health and isolation challenges. And so there's all tied together, as all tied together. We can't really parse out the mental health and the substance use disorder aspects. They really are interconnected.
And with such a great need, where do you go to get funding for the Community First Responder Program?
So we're always applying for grants. I applied for some grants over the summer that we weren't successful in getting, but we never are going to stop trying. So we keep applying for grants. We have been blessed that we have had some donations, some anonymous donations, likely, people who have been touched by the opioid overdose epidemic. So we've had some corporations, and so we have received donations to the URI Foundation, but grant funding is really what we are looking for, and we'd like to have a sustainable source of funding so that we can make sure that we can get naloxone to these programs that are out there in the community.
Now, let's say somebody has an injury or surgery and they need opioid pain medicine. How can they avoid from becoming addicted?
So what we always talk to people about is to get the lowest amount that you need for the procedure that you're having. What tends to happen is there may be a prescription for, say, 20 tablets. People will only need 1 or 2 of the tablets to actually treat that acute pain. And then they wind up sort of saving the other 18 tablets for a rainy day. And that's where, we see recreational exposure, particularly among teenagers and young adults, from that exact scenario, getting it from the medicine cabinet. So that's, one thing. Oh, you can always ask the pharmacy, just give me 2 or 3 tablets and then go back if you actually need more for pain. That's a relatively new law within the last couple of years, that you can get a partial fill of opioids. The other thing is, many procedures, you really don't need opioids. We're finding that opioids are most helpful in cancer pain, end-of-life pain. So if you can get away with using an NSAID like ibuprofen or naproxen or acetaminophen, or even a combination of the two, going back and forth between the NSAID and the acetaminophen, you can get pain relief from most procedures, even, pretty invasive dental procedures, without opioids. The data is really suggesting that you don't need opioids for that.
And that's really helpful to know, especially about talking to your pharmacist and getting a smaller amount. Now, what support can people get after surviving an overdose?
So peer recovery is really, something that we advocate for and we help to connect people to. So having a support system of people who have also gone through, opioid use disorder and are currently in recovery. We have people that we collaborate with who have experienced multiple overdoses. In fact, one that I know well has shared with me that they had 28 overdoses and were revived with naloxone. And it was that 29th time that was, the time that they were willing and able to get into treatment and recovery. So we never want to lose hope. Sometimes I think people get jaded. They say, well, this person, they've had naloxone multiple times and, kind of almost want to give up on that individual. And really, we never know when is going to be that time that someone's ready to get into treatment and recovery. And the best support is really that peer support. And there's a lot of wonderful organizations in Rhode Island, Project Weber Renew, Anchor Recovery, PSN, that can do that peer-to-peer mentoring and support, as well as making sure that people are being treated with medications. What I see a lot is pressure for people to get off of methadone or buprenorphine, which is Suboxone, even by well-intended family members and friends, because they see it as trading one addiction for another. They're like, you were using, heroin or cocaine or whatever it was. Now you're on this, is it any better? And the answer is absolutely it's better. Methadone and buprenorphine do not have fentanyl in them. They are made in licensed, manufacturing facilities. It's pure, it's regulated, and the dosing is stable. So it's just, really important that people get that medication and they don't feel pressured to come off it. You might need it for months, years, or even decades, just like you might need insulin or your high blood pressure medication for months, years, or decades. So we really want to help people and families understand that treatment is so important.
Thank you. And one last question. How does the Community First Responder Program involve students?
So we have students really built in to the entire scaffolding of our program. So actually, when we first were funded, I had students who got us, through the IRB process. They were right there with me. They helped to create, the slide decks that we use for going out in the community. They go out and do educational programs. They do tabling events to give out Narcan kits in the community. They also provide webinars and education, and they just get groups excited about it. So they talk to, for example, the Pan-Hellenic, so the sororities and fraternities here at URI. It was our students who reached out to them and said, hey, do you have naloxone at your houses? And really got, them to want to do a training. And same with the dorms and the residence assistants. So the students are they're involved in every aspect, even data entry, as you know. So, because that's maybe our least favorite part, but it's very important.
Thank you, Dr. Jacobson, and thank you to all of you for joining us today. As mentioned, within the next few days, you'll receive an email with a link to today's recording, along with Dr. Jacobson's recommendation for further reading. And we hope that you'll join us at the next faculty office hour on November 3rd, featuring Dr. Jamie Ross on age-related brain disorders. Thank you again and enjoy the day.